All right, today we're going to talk about sacral somatic dysfunctions and muscle energy techniques to treat them. And our first example is going to be for a forward sacral torsion. So I'm going to be doing some different techniques and touching some areas around your pelvis and your low back. Is that okay? Great. The first example of somatic dysfunction that we're going to treat is a left-on-left sacral torsion, which is an anterior type sacral torsion. So to treat that, go ahead and lie down on your left-hand side. All right, so we're going to position her on her left side to engage the left oblique axis for our left-on-left torsion. Then we're going to be monitoring throughout at the sacral sulcus and the PSIS. In order to engage our barrier for L5, which is rotated right in a left-on-left sacral torsion, we're going to rotate our patient to the left. So go ahead and turn your body to the left-hand side. Good, and we're going to stabilize the pelvis there. Switch our monitoring hand. Pull our chair closer because we're going to need it in a moment. And now, in this instance, we're going to further flex the knees and the hips until we feel a movement at that sacral sulcus, which indicates that we are approaching our barrier. So then once we get to that point, and I'm going to also shift you slightly towards the edge here. Once we get to that point, we're going to sit down. We're going to support our patient's knee with our leg, or with our thigh, and we're going to put knee over knee to try to get the best side bending possible. And we're going to be pushing our patient's ankles down to the floor. So this motion helps to encourage our sacrum to rotate towards the right on that left oblique axis. So we're going to push inferiorly until we feel movement at our monitoring hand. Then we're going to instruct our patient to lift their feet up to the ceiling. Go ahead, push up to the ceiling. And we're going to hold with an isometric force. Then go ahead and relax. So when they relax, we relax. And then we, after a few moments, follow that movement down to the next barrier. And then go ahead and push up again. And then relax. And then we meet the next barrier. Go ahead, push up again, and then relax. And then we go to the next barrier. And we're going to stop there at that third time. There's a little bit of a passive stretch that we can introduce at that point as well. And then we're going to return back to neutral and reassess. So back to neutral would be just swinging these feet out. And then now our patient's prone and we're back to neutral and we can reassess our sacral points. If we had instead a backwards sacral torsion, and for this example, we're going to use a right on left sacral torsion. We're going to position our patient similarly, but we're going to kind of twist our patient in a different direction to engage barriers a little bit differently. So go ahead and lie on your left side for me. So now she's going to be on her left side. We're going to engage that left oblique axis again. In this instance, in a right on left sacral torsion, our L5 is going to be rotated to the left. So to get to our barrier, we're going to ask our patient to turn to their right to engage that L5 barrier. And we can also kind of drag them into that rotation while monitoring at the PSIS and sacral sulcus. While we're there, we have them just kind of relax this arm. You can relax it wherever. We also want them to reach down with this arm and grab the table there. So again, we're monitoring at the sacral sulcus and PSIS. And we're going to swing our patient into flexion here. But instead of using both legs to engage our barrier, in this instance, we're going to take this top leg and we're going to bring it a little bit more into flexion. Sit down and let that leg drop off the edge of the table. In this instance, this motion is helping to encourage anterior motion or left rotation of the sacrum on that left oblique axis, which will help us to move the sacral base anteriorly. So in this position, we're going to just stabilize right at where we would feel the barrier is. And then we ask our patient again to push their foot up to the ceiling. And we're just going to resist. And it's just no more than a few really ounces or maybe a pound of force. Then we have our patient relax. We pause and follow to the next barrier. Then go ahead and push up and relax. Pause and push down into the next barrier and push up again and relax and pause and to the next barrier. And then at the end there we could add a little bit of passive stretch, and then to return them back to a neutral position, we'd bend those knees, swing her pelvis back up, so then she'd be in that supine position, and then we could start our evaluation of our sacral landmarks again. The next technique that I want to go over would be for a muscle energy for a unilateral sacral flexion. So for this technique, we're going to have you flip over onto your belly. Good. And so in this instance, our example is going to be a right unilateral sacral flexion. So in a right unilateral sacral flexion, our right sulcus is going to be deep and our right ILA is going to be posterior. The right sacrum is also going to be a little bit inferior as well, or caudate. So what we're going to do is we're going to try to engage our barriers of motion, which will be posterior motion at the sacral base and a cephalad direction of force. So in this instance, I'm standing on the opposite side. It could also be done on the same side, but on the opposite side, I would find where the sacral, I would find where the ILA is. Here it is. So when I'm at the ILA, I'm going to make contact, in this instance, with my hypothenar eminence. I could also use my thenar eminence as well. However, I can make best contact with that ILA. And my forces now with this ILA are going to be anterior down to the table and superior cephalad up to the head. Now, if I was to try to do this right now, I may be able to engage the barrier well, but I also might find a bit of resistance because right now that sacrum and ilia are in a closed packed position due to the position of the leg. So what I can do to encourage motion at that sacroiliac joint is abduct the hip and internally rotate the hip, and just ask my patient to try to leave that leg in that position. What that's going to do is it's going to draw the innominate away from that sacrum, which is going to open that sacroiliac joint just a bit so we can encourage motion through it as we perform our muscle energy. So again, finding our ILA, contacting, and here we're going to push anteriorly and cephalad, and our other hand could either support or it could just stabilize our patient. And then we're going to, in this instance, use respiratory assist. So we're going to have our patient breathe in. As they breathe in, our sacrum normally would move into extension, which is the motion that we want. So we want to encourage that motion. When we have our patient breathe out, their sacrum is going to want to move anteriorly. So we're going to resist that motion by pushing an anteriorly and cephalad on the ILA, which is going to help rock that sacral base posterior on that right side. Go ahead and breathe again. With that breath in, we're going to enhance our motion, and breathe out, and we're going to resist the sacrum's need to flex. And one more time. Good. And then out, and we're going to resist that. Good. Excellent. If instead we had a right unilateral sacral extension, we would use that same idea of understanding where our landmarks are and where our barriers are to treat that same side in just the opposite way, right? So with a right unilateral sacral extension, our sacral base or sacral sulcus is going to be posterior or shallow, and our right ILA is going to be anterior. The sacrum on that side is also going to be superior because it's a superior shear. In this instance, we're going to kind of shift our point of view and our direction of motion to place more attention at the sacral sulcus. So make sure to find that sacral sulcus. And your contact will be at that sacral sulcus using the hypothenar eminence, or you could also use the thenar eminence, but it might be a little more precise to use your hypothenar eminence. The right leg also, to enter that open packed position, would be into abduction and a little bit of internal rotation. You can go ahead and relax and just let your leg stand where it is. And I'm going to use my other hand in this instance to help encourage that internal rotation and abduction. With my hypothenar eminence, I'm going to put an anterior and inferior force on the sacrum, on the sacral base on that side, to encourage flexion, which is our barrier in this instance. And I'm going to have my patient breathe in. When they breathe in, that sacrum wants to move posterior, but I'm going to resist that motion. When they breathe out, I'm going to encourage the sacrum to move anteriorly and inferiorly. And go ahead and breathe again. And I'm going to resist. And then follow downwards. And I might not see too much movement, but really I'm feeling for changes in that tension and position. Good. And then I would bring my patient back to neutral and reevaluate my landmarks. Our next example is going to be a bilateral sacral dysfunction. So bilateral sacral flexion is going to be our first example. For a bilateral sacral flexion, we would expect our sacral sulci to be bilaterally deep and our ILAs to be bilaterally posterior, as the sacrum has symmetrically kind of shifted anteriorly on a transverse axis. So in this instance, in order to encourage the sacrum to move into its barrier and to move into extension, we're going to find our ILAs and we're going to put the palm of our hand on the inferior aspect of the sacrum, so under that transverse axis. We're going to support that other hand, and we're going to be, again, using respiratory assist. So we're going to have our patient take a breath in. Sacrum is going to move posteriorly, which is what we're looking for. And then on exhalation, sacrum is going to try to move anteriorly, and we're going to resist that. And then breathe in again. When they breathe in, we're going to encourage into further exhalation. And then with exhalation, we're going to resist. So breathe in again. So we're going to encourage more extension. And then breathe out. And we're going to resist that sacral flexion. And then we would reevaluate our landmarks. For a bilateral sacral extension, the opposite is going to be true in terms of our landmarks. Our sacral sulci are going to be bilaterally shallow. Our ILAs are going to be bilaterally anterior. And our sacrum overall is going to be extended symmetrically around that transverse axis. So in this instance, we're going to do exactly the opposite of what we did with the previous technique. And we're going to instead place the palm of our hand at the sacral base. So make sure you are at the sacral base. And once you're at the sacral base, you're going to push anteriorly to engage that flexion barrier. You're going to support with your other hand. And you're going to have your patient breathe in. When they breathe in, you're going to resist that extension. And then when they breathe out, you're going to push further into flexion. And then breath again. And out. And follow. Deep breath again. And resist. And out. Good. And then you would reevaluate your landmarks and evaluate for improved sacral motion.